morning, everybody, and welcome to another episode of the DIDAS Health Working Group. My name is Peter James. I'm leading this working group, and I'm very glad we have a special guest today. It's Helena Holma from Sweden with a very interesting project. I'll say a few words about DIDAS Health, then I'll pass over to Helena for her presentation, which takes around 20 to 25 minutes. Probably a little bit shorter. And then we have time for questions and discussions. Quick explanation what DIDAS is. DIDAS is an association which is very closely related to the Swiss EID activities, basically adding to the growing trust infrastructure which will be provided by the Swiss EID. There are a number of groups. We have some horizontal groups, some technical groups, some legal governance groups, and we have some verticals, and one of them is the health area, which I'm leading, and we have mobility, finances, logistics, verticals building on this trust infrastructure. Here you can see the groups. You can also find it on the website of DIDAS. And one of the activities which we are doing, there are occasionally hackathons in Switzerland. So last one was 24. From the health group, we submitted a challenge, which is basically EPD 3.0, and we were passed on an award by the Swiss Chancellor because it was a very futuristic approach. And the next hackathon will take place end of May of this year. We are planning to submit more challenges in the health space area. And for those of you who are up for it, then you're welcome to join. I would quickly jump to the introduction of our guest speaker today. I'm very glad we have Dr. Helena Holma, a medical doctor, and she's the CEO and co-founder of Leyr. She's a physician originally in internal medicine with lots of digital health experience. She raised 1.5 million euros for the Leyr company, and she is nominated as the most important female entrepreneur of the year. Helena, thanks a lot for joining us, for taking the time, and the floor is all yours.
Thank you so much for inviting me. I can also give you an update. I didn't win. I was nominated, but I didn't win that most important female entrepreneur, but it was an honor to be nominated. Yes, so it was a very nice introduction. Thank you so much. I will give you also a bit about my background and why I am doing what I'm doing today. The title of the presentation is How Leyr, my company, is busting health data interoperability challenges. So I'm going to present, what we do and why we do it, but also then talk more about an interoperability hackathon that we had or participated in last year and our conclusions from that. This is me and my co-founder. We're a team of 8 people, but we are 2 co-founders. It's me, Helena Holma, and as Peter mentioned, I'm a medical doctor by training. I worked 10 years as a clinician, so I'm a specialist in internal medicine, but I joined a Swedish health tech startup 8 years ago. And that's where I learned like product development and regulatory compliance in digital health and patient safety, risk assessment, and so forth. As a clinician, I was used to copy pasting to transfer data between different systems. I used fax machines and scanners. The swivel chair integration, as I've heard now that it's called. But then when I joined Doctrine, the Swedish health tech startup, I could see how difficult it was to actually integrate our platform to mainly the electronic health records, the EHRs, because that's where the main documentation administrations take place in healthcare. And it was when I was at Doctrine that I got the idea for Leyr, or what then became Leyr. And it was when I was watching a webinar by a company called Leyr, who was then a startup in open banking. Now they're a scale up or in fintech. So what they did was basically a unified API to let fintech applications connect to multiple banks through just one connection. And I was like, well, this is how it's supposed to be done in healthcare as well. And I thought about that for a year, and then I decided to build it myself. But I needed to find a co-founder. So I applied to an accelerator called Antler, and that's where I met my co-founder Anton, who has a technical background in open banking and fintech. So he had actually built these integrations in fintech previously, and he knew exactly what I sort of had in mind. So we started building Leyr together, and that's 4 years ago. The challenge that we want to solve is that health tech companies, or rather healthcare organizations and healthcare providers, they have a difficult time just introducing more and more digital tools that are not integrated with their EHRs, because it disrupts their workflows essentially. And this means for health tech companies that it's difficult to sell their products to healthcare if they're not integrated. So EHR integrations has become quite a critical need or must have for health tech companies to be able to get their products on the market and to scale it. But unfortunately, it's a nightmare to integrate with EHRs. I made a little star there. Not all EHRs, some are easy to work with, but the majority is very difficult. And these are just three reasons. You get very poor documentation of the API, of the technical specifications. Once you start building, it's difficult. They don't have test environments. If they do, it's not production-like and so forth. And then there's a bureaucracy it takes forever to get access, to get credentials, to get the right documentation and so forth. And I've experienced this firsthand when I was at Doctrine. On top of that, the EHR market is extremely fragmented. For example, there are thousands of EHRs, electronic health records, worldwide. And if we look at Sweden, we have one large EHR vendor, but we have many, many smaller different EHRs that are critical for health tech companies to integrate with as well. And on top of this, many healthcare providers, they use more than one across their organization. So you cannot be satisfied with just building one integration. You have to cover lots to get access to the market as a health tech company, essentially. Leyr, what we do is that we let health tech companies connect to any EHR through one quick integration through our platform. And here it says our customers, they integrate in less than 2 weeks, but it has been like a few hours for some customers, and our record of starting to integrate and going live in production is less than 24 hours, which we're very proud of. We have built a sandbox where you can test integrations before you go live, which is quite nice. We also focus a lot on user friendliness, because if it's easy to build these integrations, it's easy to make it right, and that affects patient safety in the end. So essentially, this is what it looks like. So our customers, they connect once to us, and then we handle the complexity on the backend side, integrating with all of these different EHRs. I say health techs, but we also have Meliva as a customer, which is a large healthcare provider, actually, and they have their in-house applications that they need to integrate with the different EHRs that they use across their organization, and they use Leyr for that. So it's both health tech companies and sometimes also healthcare providers directly that need this. Yes, and I also want to, of course, emphasize that we share patient data and health data. So it's very important for us about information security and to be compliant, of course. And health tech companies, they can be small, but they can also be large enterprises, which we also can serve, of course. These are just examples of how we work with information security. But we use double encryption, so we cannot access our customers' data. That's very important. We have thought a lot about our design so that it's secure by design. We don't store any patient data. It's just in transit, and it's encrypted in transit. And then we know that there are a lot of on-prem solutions in healthcare. So our solution, it can run both on cloud or on-prem. We prefer on cloud, but yeah, we know the reality. So far, we have integrated 30 different EHRs, and we have 70,000 daily transactions towards our API. And when I say transaction, I mean API call, essentially. We're live in 3 countries. It's Norway, Sweden, and Denmark. We have a very global vision because it's a global problem to integrate with EHRs. Companies from all over the world are reaching out to us and describing exactly the same problem. So we are just getting started. But now I want to talk about the Nordic Interoperability Hackathon, which is more the focus actually. And this took place in March last year. We were one of the participants. The main, like the goal of this hackathon was to build interoperability solutions for health and social care using open standards. So everything focused around open standards like OpenAir, FHIR, and so forth. And I also it was a Nordic hackathon, but the setting was the Swedish healthcare system. And in Sweden, healthcare is under the regions and social care is under the municipalities. So there are different authorities involved, and that makes it, from a regulatory perspective, trickier to share data between regions and municipalities. So that was also a challenge for this hackathon. What I liked as a medical doctor was that everything was centered around a patient. His name was Arne. He had multiple chronic diseases, and he was also in need of home care. So he needed both healthcare and home care, social care. And the hackathon was organized by Stockholm University and Karolinska Institute, supported by Health Data Sweden. So we got funding from the European Union. And we were one of the participants, and the participants were health tech companies, med tech companies, also representatives from authorities, EHR vendors, suppliers of CDRs, clinical data repositories, and also patient representatives from patient organizations, just to have that patient focus in mind all the time. Now I'm just going to talk about what we did. So we were one group, but there were probably 10 groups, and we could talk about the results from this hackathon a whole day. But this is our group, and I also want to mention, since I show all these logos, that this was a temporary collaboration during the hackathon. So we are not like customers or partners or so forth. So this was just for the hackathon that we collaborated in this constellation. One of the companies was Colabodoc. That's a Swedish health tech company, and they provide a communication platform between healthcare provider and patient, and also healthcare provider and social care. So they have actually solved this communication and sharing data between the regions and the municipalities. And this is one of their products that they had developed before this hackathon. And then part of the group was also CGM, which you might know, it's a large medtech company, but specifically for this hackathon, it was their product Take Care, which is an electronic health record that is used in Sweden in primary care and specialist care. And then it was Leyr with our interoperability platform. And then also part of this hackathon was these companies that you see, Cambio and Tietoevry. And they were not part of the group, but they, as part of the hackathon, they gave access to their CDRs, their clinical data repositories based on OpenAir, for free. So we used both of their platforms in the hackathon project. This is the patient scenario that we wanted to solve the challenges within, so to say. It's the patient journey across healthcare systems, and it was this patient Arne with multiple chronic diseases. And the story was that he had an initial visit at his primary care center, and he booked this visit using Colabodoc, this platform for communication and with healthcare. There was a medical note created in that platform that was automatically transferred through Leyr to Take Care, the EHR that they use in the primary care setting. And then they referred this patient to the ER, the emergency room, where he was admitted. And then from there, he was discharged to a nursing home. And the final note was made in Cambio, another EHR. And at the nursing home, the responsible nurse could communicate with the responsible doctor in primary care using Colabodoc, this communication platform, and her note was automatically transferred to Tietoevry, which is the EHR used in social care, and the doctor's notes transferred to Take Care, the EHR used in the primary care setting. And this was like a schematic view of how we solve this to share data between these different authorities, and healthcare providers. What you can see is essentially we used Leyr as a glue between these different systems. And what we could achieve was to actually connect the legacy system to this CDR using OpenAir. We could also connect third-party application, Collabodoc, to a CDR. And Collabodoc, they have their own proprietary data format, essentially. They don't use that as standard, neither does this legacy system. But we could map that to OpenAir so that they could easily connect. Through this, we could ensure that the communication was seamless. Nobody had to copy-paste or use fax machines and scanners. And we ensured that the data followed the patient, essentially. And this hackathon, it was 48 hours. I think coding was 24 hours. There was a lot of sort of administrative things to figure out and to do the mapping and so forth of the data formats. My key takeaways based on this hackathon, it was a very insightful hackathon, I would say, because when everybody was in the same room and collaborated, we could achieve anything. That was very clear. So I would say that data blocking is the main issue, why we don't have interoperability, full interoperability today. It was also very clear that we need access to APIs. So if a system doesn't have APIs, they need to provide it somehow. Otherwise, it's going to be obsolete in the future. But also, common interoperability standards are complementary to each other. That was also very good insight during this hackathon. We need to figure out how to have these standards working together because they have their specific purpose. And once we have figured out how they work together rather than competing with each other, it's much easier to achieve interoperability. And then the last question. Where shall we be in 5 to 10 years? And what do we have to decide now to get there? Well, where shall we be? I mean, it was so obvious what we could achieve during 48 hours that within 5 and 10 years, we can achieve full interoperability to share data, have patient access their data, but we need to implement regulations prohibiting data blocking. That's what we need to do. It was very clear to me during this hackathon. The technology is there, the regulatory, information security, how to share data, we can all adapt to it, but we need the access. And that was my main conclusion.
Helena?
And I just want to say that's my QR code for my LinkedIn profile, so it's not a scary QR code. But thank you so much.
Thanks a lot for your insight, Helena. Well, that sounds very familiar to us. As you quite rightly stated, I think this is a problem which everybody has. And I'm in this environment for about 10 years, and the complaint about lack of interoperability, I'm hearing that since I'm in this field. And I have a lot of questions. I'll raise my first one, which interests me most, but I'm pretty sure my colleagues have questions as well. So about this interoperability standard. So you mentioned OpenAir, there's a FHIR standard. You also mentioned that they are all built for a special purpose. What's your experience if you could have one wish, what you would like to improve with regard to these standards? What should be improved with the standards to achieve a better interoperability going forward?
What should be improved? I think, first of all, they are when it's quite a sensitive topic with standards. It's easy that it is this competition between different standards, and I would that's not going to get us to the future. So I think more of like being super clear what's the purpose of the standard also, but also for like health tech, it was also quite clear in this hackathon that these standards are quite difficult for developers who just want to build a product. So I think having super clear use cases and why it's supposed to be used for which use case, and why we need them, because that's not clear to the developers in the different companies. But also when and where does this standard, why do we need this standard for this specific purpose, to clarify that.
Okay. The reason I'm asking this, in
Yes.
Switzerland, we have a situation, we have a national electronic health record, which has so far cost about 1.4 billion. And we have, Switzerland has a population of about 9 million people, and we have about 100,000 records, which is less than 1%. And the solution was designed about 15 years ago, which is today based on PDF documents, more or less, with a user interface which is not too brilliant, so you cannot even have folders. So I think in the meantime, everybody has understood that that is not the way forward. If you have a citizen with one or more chronic diseases, you easily have a few hundred PDF documents, and no physician will open these documents and read them. So what you need is actually a structured way. So that is in the meantime accepted. So there's an effort underway to store clinical data in a structured form, and there are two main competing standards. Obviously, it's FHIR and OpenAIRE. It's now moving towards FHIR a little bit more. I understand there are some efforts on the way to adopt the Danish system, which is based on FHIR. And in this group, we have a few colleagues who are in the OpenAIRE working group and modeling group. And I think the current positioning here is OpenAIRE is more geared towards the patient path, if you like, and FHIR is actually more geared toward a data exchange between legacy systems. And my question was aiming a little bit towards the future solution. So today's solution, as you correctly mentioned, you have the same situation here. We have a number of legacy systems which have grown over the last 30 years with proprietary standards. But if we would be in a position that we have systems which are based on OpenAIRE and common OpenAIRE standards, they should in principle be able to exchange their data in OpenAIRE format directly, not even going through FHIR. Do you think that's realistic, or do you think we would still need FHIR as an exchange layer?
I think it all depends on how we design the technical solution. I think it's definitely realistic to exchange data in OpenAIRE. That's what we did, essentially, in this hackathon. We didn't use FHIR or go through FHIR. We did this directly with OpenAIRE. However, what we also learned is that OpenAIRE is it's a difficult standard or complex, I should say. So I don't think it's realistic that all companies would have that knowledge in-house, how to connect to OpenAIRE, sort of, or make use that they should use the OpenAIRE standard. We need to figure out how to share data with that. I mean, Leyr is one solution, but there could be other solutions as well for these companies. What I also want to emphasize on what I learned was a big insight during this hackathon is that, I mean, OpenAIRE, as my understanding, please correct me now if I'm wrong, but it focuses on the medical data, like the clinical data. And in healthcare, there is so much administrative data that is equally important, and we need a standard for that as well. So that's also what I mean when it's complementary, that we need to ensure that we can exchange the administrative data as well. But yeah, I mean, I'm a very big believer of OpenAIRE.
Yeah, that's exactly the discussion which we're having as well. So the clinical data, it's OpenAIRE certainly a good candidate. How did you solve the administrative data issue? Did you go back to FHIR, or did you define your own proprietary standards?
We have in our API a proprietary standard for booking appointments, essentially, which was in this hackathon the use case. You can also have it in FHIR format if you want through our platform, but no one has requested that so far. So we used our proprietary format for that specifically, and then we used OpenAir for the clinical data in this scenario.
And coming back to one of your statements about using OpenAir in the companies building that or interfacing, that's also my experience. So very often you have technical people and you also have clinicians who want totally different worlds. And my understanding is that the technical persons do sometimes have very limited knowledge about the clinical things. I was even joking about that with my colleagues. They prefer to have regular expression for insurance numbers much more than dealing with clinical data. What would be your recommendation to bring these developers up to speed on the clinical side, something like crash course, software development kit, or whatever? What would be required to expedite this adoption process?
I mean, I think the key is a team with several competences within that team. I'm not sure that it's one course would. I think one course could give developers insight in how much they will need clinicians to actually build this. And also, I mean, at Leyr, we're clinicians and we're developers. What we are missing is health informaticians, which we also collaborated with, because the universities in this hackathon provided the students in health informatics. So it wasn't enough with just having the clinical perspective when we did this mapping towards OpenAir. We needed help with from health informaticians as well. So a multidisciplinary team is required, and that's also challenging. I'd say.
You just mentioned one thing which sprang to my mind. So you mentioned this mapping. So obviously you have to do a mapping from all these legacy systems to these standards. How complex would you judge this one? So was that more an easy task or was that more challenging? So I could imagine that's more challenging part.
Yes, it was very challenging. And for this hackathon, we had to sort of scope it down so that we could achieve this within like 24, 48 hours, scope it down as much as possible, because we realized that it was a very large scope initially. But it takes, I mean, it's the mapping is one thing, but then you also have to test it and verify that it's correct, right? So it's yeah, it's quite a lot of work.
Yeah, it's a step-by-step process, I would get. So one last question from my side before I open for my colleagues. I mentioned we have this hackathon in Switzerland. It's a GovTech hackathon. It's not a medical hackathon. End of May. Could you imagine that you could join this hackathon with your solution, or another hackathon in Switzerland?
Definitely.
Okay, so
Yes.
once we have it, I'll come back to you.
Yes, please.
Cool. So Dominic is posting one question after the other. Dominic, you certainly have tons of questions. And you should go on mute.
Exactly, I needed to unmute. I just kind of dropped a few thoughts in the chat to trigger some discussion. I think I leave it for Helena to pick any of those she wants to respond. Commercially, kind of the scope on where you are as a company, where to, let's say, to what extent have you been operationalizing, in what geographies, across which kind of customers. That would be of interest for anyone who could think about collaboration, I think, and likewise for you also to position yourself. I would secondly also be interested to see or to hear your perspectives about the future role of agentic AI in this domain, as opposed to hard-coded API.
Yeah.
And a regulatory question in terms of, I'm anticipating that you will get some form of competition from the European health data space and the national implementation of that. So wondering how you position and attack this development?
Yes, I love the question.
Plenty of substance.
Yes, we can start on the current scope of connected systems, because that's probably the easiest one. So because interoperability in healthcare is such a huge topic and task to like take on. So what we have done is we have built our API step by step. So first we started with administrative data, booking appointments. And it's just not connecting the endpoints to each other, but it's also designing a smooth flow within the connection, so to say. So we have booking appointments, we call it a use case. And it's more than 30 EHRs connected to that. And then we have documents, because PDFs are still something you want to transfer between systems, mostly for archiving. That you can do. And then we have medical notes, and that starts to be complex, right? Because now we're talking medical data. And within those medical notes can also be lab results and vital parameters and so forth. But I would say, and then patient demographics, just SSN and address and phone number and so forth. So we have those 4 use cases and building it step by step and adding more use cases. And geographies, it's we're regulatory compliant within the European Union, but we're live in Norway, Sweden, and Denmark. We're growing through our customers, and the customer felt they needed to go to the US, so we're actually looking or working to go live in the US as well. And then the EHDS question is yes, we're definitely in scope of the EHDS regulation. And Leyr's part in that, I would say, is that there are a lot of health tech companies that haven't yet realized that they will be affected by the EHDS, given how EHR is defined. It's a very broad definition in the EHS. So basically all health tech companies that store any kind of patient data will be defined as an EHR and will need to share their data through this specific standard. And I see Leyr as we connect to this standard, and then you can easily share your data through Leyr. That's how I see it. So I don't see it, I don't see it as a competition. I see it as an enabler. We're following it very closely, and we will find our position in the EHDS. And we can already exchange. Technically, we could. It's not possible because we have disabled that, but we could share data between countries already, but we don't. And then we have those other. Oh, I like these questions. Have you thought of building agents using MCP? Now, I don't have a technical background, but I can say yes, because we had a discussion regarding this, and I learned a lot yesterday. What we do see is that we want to build MCPs to enable other companies to build the integration towards us, actually. Because what we do see is that there are a lot of clinicians out there that are vibe coding their booking apps, for example. And then they can, it's difficult to vibe code interoperability, actually. But for those, booking applications, I would say, that's the common use case we see, that clinicians want to develop themselves to enable patients to book appointments easier. But then we need to be able to facilitate the integration towards us in an easy manner. So that could be one use case. But then I see AI in the interoperability domain. So we're not an AI company, but we use AI operationally in-house. Yes. The challenge is that these APIs, they differ so much. Even if they have standards like FHIR, they differ. So you need quite a lot of volume. You need access to a lot of APIs to develop those AI agents, essentially, which we will do. No, but we definitely use a lot of AI to build our integrations ourselves, and I do think that's the future for sure.
Dominic, any other questions?
No, thank you. Interesting insights.
Okay. Other questions from other participants? Yeah, maybe a few words about this AI discussion. Of course, we have it here as well, and actually two groups. So we also have an organization which is called Gesundheitsdatenraum Schweiz, or Swiss Health Data Space. It's actually an association right now, and our official Federal Office of Public Health tries to capture the domain name because they want to have it. They missed a little bit registering it. But the president is Ernst Haven. Actually, he wanted to join us. I can't see him and the participants. Yeah. So Ernst Haven, he is very much in the AI topic, and he's coming more from the image analysis, such as X-rays. So there, I think AI, if you train it properly, can do a pretty good job. On the other hand, using AI for pretty much everything is a high risk because it very much depends on the quality of the training data, as you all might have guessed. And coincidentally, I just did my personal health checkup, a very wide range health checkup a few days ago from a lady who is a professor at the University of Basel. She's a family doctor, and she's actually teaching how to do these type of medical checkups. And she has developed a sort of a checklist, a clinical checklist, what needs to be investigate. We had a discussion about that, and you need a curated checklist done by some clinical experts. Otherwise, the AI does some guesswork and comes up with strange things. So talking about this AI, on the one hand, you have these specific pre-trained models. On the other hand, you need the clinical background, which is curated by the clinicians to get the right quality. And that's currently what's going on. Coincidentally, I'm running a project about linked data and knowledge graphs, and that's probably where the future is. So you have curated knowledge graphs where you put in the clinical knowledge, and then you can run the AI against that. So that's what's currently being discussed here, probably in other countries as well. Okay, I saw another question. Who was that? It was Gerard was actually raising his hand. Yes.
Thank you. Thank you for the presentation, Helena. Very many interesting insights here. On the soft side of things and the change management aspects, any insight on how to provoke the change and how to trigger the adoption of this technology by this fragmented environment?
Yes, that's a very good question. And actually, so Leyr is 4 years old, and when I had one of the first presentations, maybe that was in 2022 or early 23, I presented Leyr for a hospital in Stockholm, just because they wanted to know what's happening in the startup world, essentially. So it wasn't a pitch, it was just a presentation of this is what we're doing. And that was the first time that I presented to doctors and nurses and like clinical professionals. And I had my presentation, and then one doctor said, he was like, yeah, I mean, this sounds great, but I've been told for 20 years that this is impossible. Like, how can you come here and say that we can actually exchange data between systems? And that made me realize that, like, healthcare really needs to understand that this is possible to actually do from a technical perspective. It's very rarely the technical side that is the issue. But also on that, for example, with our healthcare provider that we have as customers, we have worked with their clinicians on how to design the solutions, because integrations is very technical, but it affects the workflows on the floor. So we need to have the clinicians on board on how do you want this to work and how do you want this to work for your patients. So to have that dialogue. But also, thanks to the European health data space, for example, interoperability is on the table. It is being discussed. And I was so happy, like half a year ago, when I saw doctors writing a debate article in the newspaper, we need open API so that we can connect our systems. And I think that is one of the main benefits of the EHDS, that it has actually brought interoperability up on the table and being discussed also from a clinical perspective. So yes, we need to push more on the clinicians to understand that it is possible to share data and improve the workflows.
And if you had a joker of an incentive you could create in order to provoke this adoption, what would be the incentive that would give the best results in your market, would you say? Because I understand the technology. I understand that people might not see it as possible today. So there is a communication effort, but some blockers are also related to people's behaviors.
Yes.
And so what would be that incentive that could suddenly create a virtuous circle?
Yes, the joker is the regulations, the forcing regulations. And why I'm saying this with so much certainty is because we are inspired by open banking. And if we look at open banking and the EU, that was enabled by the PSD2 regulation that came 2016 that forced the banks to open up their APIs. Otherwise, they wouldn't have. And I know, Swedish startups were involved in actually promoting those regulations. We often talk about regulations as kind of restricting, but regulations can also be used to open up systems and ecosystems, and that's what we need. That's the joker.
Thank you.
Probably on that note, in Switzerland we have now this large program which is called DigiSanté, which is funded with about 400 million over 10 years. Initially, they wanted to refuse to adopt the EHR. I think in the meantime, they have accepted they have to deal with it. And one of the drivers is Katrin Krameri. She's actually a very strong personality, and I had exactly that discussion with her more than once. So what regulation and behind that is actually in investment safety. So if there is no safety for investments for these companies, they just don't move. And that's actually what happened in Switzerland, because everybody was waiting for somebody else to do certain things. And I think the role of our Federal Office of Public Health is to define these guardrails on the left and the right side, so the investing companies know what they have to expect. And that's actually the job of this central organization. A lot of people are afraid that there's a central database with central patient data. I think that's not the issue. We need central standards. That's the important thing. And once you have that, and they need to define it, they need to put it into law, and they need to publish it. And that only partially happened in Switzerland. There's an organization which is supposed to do that, but they only did it partially, very sadly. But then the next step is, if you have a public tender for the next purchases, then you need to put that as a mandatory condition. I was doing these sort of tenders, so if it's a must condition and somebody just doesn't confirm that he adheres to these standards, I just cross him off. So he's not even invited to present his solution. So that's one side. So the providers must be forced. And for that to happen, you need to instruct the clinicians who are miles away. So they're much more impressed by flashy, colorful screens than international standards. They're purchasing this product, and afterwards they're complaining about the lack of interoperability, because the vendors, if you don't force them, they just don't do it. They rather do the opposite. So the business model of most of these vendors is lock in by design. So they try to lock in their clients to their products, and it must be a very active role. So first of all, you have to tell the vendors that's the new rules of the game, and so you have to And then you have to teach the clinicians, the hospitals, to order these things in the right way. Otherwise, it's not going to happen. So you really have to force them, because we tried it in a friendly way over the last 10 years in Switzerland. It just didn't work. So I think there's more that the purchasing process which need to be considered as well. And that was my question about the software development kit, because I'm in this field also for a while. And we did a prototype for a health app. So our idea is to have a Swiss health app. And for that to happen, you need an API to our national health record. And I was running after that for the last 3 years. I was talking to about 50 people. And they always find some excuses why they shouldn't provide that. So I cannot overemphasize the importance of these APIs, but behind the APIs, it's the proper documentation. It's not just the API itself, it's training materials, software kit, example applications. So every company who needs to incorporate that has a very quick and easy way to bring it into their solution. Well, I'm a developer by myself. Well, I don't do that anymore. But when I do it, I download it, I try it out. If it's complicated, I throw it away. So we must make it easy for the developing companies to integrate that into their solutions. So that's my take on this one. So just checking the time. We still have time for further questions.
Yes, I saw one question in the chat. How do you deal with patient identifiers across systems? And I mean, we unify that. That's our headache. Our customers, they just connect to us, and then we have figured it out for each new system, each new market that we go to.
So do you have a social security number in Sweden? I would assume you have.
Yeah.
Are you allowed to use it, is the next question.
How do you mean?
In Switzerland, we have a social security number, but there are quite a number of limitations how you're allowed to use it. And it's the big discussion if you're allowed to use it in healthcare systems. Can you use the social security number for mapping, for citizen mapping?
I mean, we use it as identifiers in healthcare, but I mean, that's part of sensitive data, considered like personal data, sensitive data. So we sort of hide that, and we don't see it, of course. But it's so we have headers. I can't go into technical details, but we use, I mean, the social security number is it's a very important part of the identification in Sweden, in all settings, and we use it.
Yeah, same in Switzerland. So we have it, the uses are limited. It's allowed for checking. So whenever I go to hospital or to a family office, they use it for a check, but typically in their own systems, they have their own identifiers. And coincidentally, I was in the financial sector for about 20 years, and I designed a system to do exactly that. So we had the central system here in Zurich, in the main branch, and we had a lot of branches in other countries. And basically, they provide their identifier initially, and we do an initial mapping to our main identifier in the main branch, and then we keep this mapping in the main system. So when everything comes along from another branch, then basically we have the mapping and we map it from the local identifier to the central identifier. It's not too complicated architecture-wise, but you have to implement it properly.
Yeah, it works. I mean, it's doable, and we see different solutions in different systems across Sweden and Norway.
Mikael has a question.
Yeah, thank you. Very interesting. Thank you, Helena. I was wondering how as you copy this data across all those systems, it only passes in encrypted form through your Leyr. But I was wondering about the challenge of authenticity of the data as the data is copied from one system to another. Was this questioned, or does this question even is raised? You know, because you're basically inputting data into some other system, and how about the origin authenticity, the integrity of the data, and how this is potentially solved?
Yes, that's a good question. And I mean, we are only the infrastructure, so we are depending on the third-party application and the EHR, and we have to perform essentially end-to-end test before we go live to verify that it's data consistency essentially, and that is correct. And that is sometimes that is very easy depending on the solution, if it's like booking appointments, but otherwise we're having a quite complex project now where it involves a lot of medical data, and then the testing is, I'd say, the large part of the project essentially, ensuring that it's correct.
So that's of course, I was thinking more about if somebody challenges, you know, you're putting data into from one system to another, and then for audit or whatever reason, if somebody wants to kind of make sure and verify that the data is really who actually originated the data, are like digital signatures involved or other technologies, or was this even raised as a challenge? One of the projects we have as DIDAS Health is portability of data. And one of the pain points we discussed is that maybe I bring my health results from one doctor to another, but they will not necessarily trust the papers I bring, and they maybe will send me for their tests to their lab to make sure, you know, that the data is authentic and correct. So you're copying this data, so it suddenly appears in their system. So maybe they don't even raise the challenge right now, right? Was the data authentic? It comes from some other lab, from some other environment, maybe goes from some other standards, you know, to be generated. So I'm wondering if this challenge even comes.
Yeah, it hasn't been encountered so far, I'd say. There is a traceability in the solutions that we have integrated. We have a medical device, for example, that transfers results from spirometry into the EHR, but there you can see where the data comes from, and it's within one healthcare provider, like one clinic, so they have already made their due diligence and accepted the medical device, and if it's not integrated, the doctor is going to manually transfer it, so to say. So it's still within one clinic, and so they do trust the data because they use both systems in-house, so to say.
Thank you so much.
So
interesting.
And thank you for raising, because it's probably going to be a challenge.
Yeah, it might come with time, and I'm asking in context of what we're doing in DIDAS with adding this assurance to data with verifiable credentials, this wallet technologies that you can think about it as signed PDFs as the data moves, that you can always verify where it came from, and maybe it would be interesting to consider as the European wallet infrastructure also spreads. To add this data authenticity layer to make sure it never gets modified, like cryptographically, ensure and expand on your already great approach of end-to-end encryption by adding this authenticity layer. Maybe something interesting to consider together.
Yes.
That's actually a good segue what we are planning to do. So as I mentioned, we have this hackathon coming along. From the open air data modeling group, we decided to go for a showcase. And in the long run, we want to cover the international patient summary. We also pick a subset, which will be immunization or vaccinations, because it's actually very easy to explain, because most people have this yellow booklet where their vaccinations are recorded. So medication is much more complex, obviously. So we purposefully picked this immunization case. We do a modeling, and the main purpose of this challenge is actually to show how open air and fire work side by side. So that's pretty much decided. We're already preparing it for this end of May hackathon. What Mikael just mentioned, because he's an expert in these security items, secure data storage, which was, we had actually a vaccination solution in Switzerland, which was a disaster. The functionality was fantastic, but unfortunately had some security holes, which ended up in a media disaster. It was called Meine Impfung, and most people know about that here in Switzerland. And the third party, and that's basically what we're planning to bring in from DIDAS, because that's more along the lines of DIDAS. And the third part, which I'm currently preparing, we have this Swiss Health Data Space Association, which I want to bring on board, and they're really aiming for person-centric and citizen-centric data. I have not yet talked to them what their challenge could be, but the idea is really to have a little bit of a push in these healthcare topics, because we really have to do something after this long exercise with the current version. And the new version is just about to be developed within this DigiSanté program. So that's what we are trying to do for this upcoming May hackathon. And if you feel for it, let me know. Then you can come and join us. Then we can see you in person there. So we are coming to the end for my time. Any urgent questions before I conclude? Not for the moment. So we will edit that. So thank you to everybody. Thank you particularly to Helena for taking the time, for sharing your experiences. Very, very insightful, much appreciated. And so we see each other. If you're interested, you can subscribe to the channel. You can like the contribution when it's out, then so you'll be notified about upcoming items. Thank you, everybody, and have a nice day.